It's lovely to meet you. So, you've recently published the Cerebrolysin and Recovery After Stroke article in Stroke Journal. Could you give us a little bit of a background on that trial?
Thank you for mentioning the CARS trial results, because it was possible to conclusively demonstrate that all neurologists who have postulated for years that stroke needs to be treated with multiple interventions approach have been right. This is exactly what we have done in CARS. The trial enrolled a total of 208 patients who had suffered from ischemic stroke. Half of the group was treated with cerebrolysin and early neurorehabilitation, the other group only with neurorehabilitation. The double intervention showed beneficial effects on motor function and global outcome in early rehabilitation patients after stroke.
So, what exactly is a multiple intervention treatment approach after stroke, and how was it done specifically in CARS?
So this is a very good question. Actually, a successful stroke therapy should approach multiple pathophysiological mechanisms beside revascularization at once. Of course, we should use pharmacological and non-pharmacological intervention, whatever will be possible to improve patient condition. And we should do this in order to prevent cell death in penumbra and also to stimulate neuroregeneration and plasticity in the whole brain. Today is a common knowledge that neurorestoration is a very powerful strategy to improve stroke patients' condition. Actually, treatments with monomodal pharmacological agents have so far not been successful. And we therefore designed a clinical trial which tested if a double intervention consisting of a multimodal pharmacological agent like cerebrolysin plus early neurorehabilitation would be superior versus early neurorehabilitation alone.
So, what's the difference from the previous trials to now? What's the difference in the testing?
So actually, it's a totally different approach because we have used as a primary outcome parameter the ARAT score, Action Research Arm Test, which is a well-established scale to measure upper limb motor function. And we could clearly see that patients who received the combination therapy did much better. I would say that they almost regained full motor abilities on day 90 after stroke. And we should notice that in cerebralizing group motor function improved by 88% according to the results.
So what was your sample size for the 90-day point?
The sample size was 208 patients, actually. And what I would like to add in this respect is that it is critically important to demonstrate that such combination therapy can be useful and also safe. And the publication clearly expressed that the benefit-risk ratio is in favor of this double intervention.
So you talked about the results. How does this then affect clinical practice?
I strongly believe that taking in consideration more neurorehabilitation in future strategies in treating stroke would be a very important point. As a matter of fact, neurorehabilitation is one of the most multimodal and powerful interventions to treat neurological disorders, actually the deficits after any kind of neurological disorder. And this is relevant, and I'm fully convinced that in the future, a better strategy to match acute treatment with a long-term treatment would be very desirable. And of course, the access to rehabilitation is not yet globally available. Even in many Western countries, we have to recognize this.
Indeed, yeah.
This is a fact. However, if a medical doctor, patients, and caregivers work together, they can achieve a lot based on the institutional care facilities and beyond. And I would like to mention also that to achieve improvement in motor function, a sophisticated environment is not always necessary. Because if a patient and caregiver focus on most essential activities of daily living and repeat it in a correct way every day, a lot of improvement can be achieved. So, early mobilization is another important point. That this early mobilization and early rehabilitation should already happen in the acute care setting, and then these programs are continued at home if the patient is discharged from the hospital. In CARS trial, the rehabilitation lasted 21 days for 2 hours daily, and then patients were asked to continue training at home. Of course, at a lower intensity, but this happened until the day 90, and this is the very important added value of all this strategy.
So once we implemented the drug, how long did the actual effects of the drug last?
Actually, cerebralizing was administered for 21 days, and we choose 30 ml daily, which has been proven to be an appropriate dosage in stroke by recent dose response trial from Michael Chop lab in the USA. Over this period, cerebralizing can fully demonstrate synergies with the neurorehabilitation procedure so that neurorecovery can truly be measured.
What other benefits can there be from this particular pharmacological intervention?
So, general neurological outcome scales like the modified ranking scale or NIHSS were used throughout the trial. And the combination therapy again shows strong superiority versus rehabilitation alone. Also, post-stroke depression was far less prevalent. Activities of daily living like bathing, feeding, dressing score much better.
So where to next? What happens next now post-CARS trial?
So CARS focused with its choice of primary endpoint on upper limb motor function and its improvement. Still, how about cognition? Cognition is a very important aspect. Would it be possible to enhance cognitive functions by a similar combination therapy approach? This could be a good question for a future research in the future.
Mm-hmm.
With cerebralizing, we have an excellent research substance in our hands because various studies show already cognitive improvement in stroke, TBI, and also in dementia. My hypothesis is that cognitive rehabilitation, as we did a motor rehabilitation in CARS, so cognitive rehabilitation plus cerebralizing would lead to a similar result as in CARS, and we might improve cognitive function as well. Repetitive cycles of treatment may also be considered in order to consolidate treatment outcome, as I have mentioned before.
Yeah.
Because the philosophy of a biological drug is to support on the long term the recovery process. So we should not stop the treatment. And this is the difference between a neuroprotective strategy and a brain protection and recovery strategy. It's totally different.
Thank you so much for your time today.
This was my great pleasure.